They feel totally disrespected by their employer, and their professional judgment is, on a daily basis, set aside or ignored by senior management, whose continuing focus is solely on budgets and numbers and not on the needs of patients and service users. Against this reality, the transformation required must begin with the replacement of lost staff, together with the recruitment of additional staff, which will require sustained investment. If you do not have nurses and midwives and other frontline staff, you do not have a health service that is fit for purpose. Transformation and what is required. In calling for this major organisational transformation programme, the INMO recognises that it must be in tandem with how and who delivers care and where that care support is provided in the context of devolved funding and accountability arrangements. The fundamental principle of our new and changed health system must be a guarantee to any service user that they will receive integrated care, whether they need it in the home, in the primary care setting, an acute hospital or in a long-term care environment. There can be no silos in terms of budgets or who delivers care, which currently are real and growing barriers to meeting the needs of patients and service users. Against this background, we now make the following points to the committee. Organisational reform. In the context of 11 years of organisational reform with no improvement, the INMO, as part of this transitional programme, believes the following must take place. Simplified organisational structures, from Department of Health to regional health authorities to individual local units and areas. There is no cohesion or accountability with the current structures, which include the Department of Health, the centralised HSE, 7 hospital groups, 9 community health organisations, 17 mental health areas and numerous Section 38 and 39 service providers. This will always result in a lack of transparency and accountability, with frontline staff not having the necessary autonomy with responsibility to shape service delivery to meet patient and client need. Transforming models of care. This overhaul must result in nursing and midwifery and medical staff being empowered with accountability to deliver care at the most effective level. In that regard, the INMO puts forward the following framework. The single-tiered service would see all new appointments to consultant and general practitioner posts involve a public-only contract, including an obligation to work rosters on a 5/7-day basis. Existing post holders in consultant and general practitioner posts who do not wish to change their contract must be allowed to retain the same. All new appointments should be replaced with public-only contracts, and this will require an increase in the number of consultants to our public health service. This can be partly funded by a reduction in the number of NCHD posts, reducing our current over-reliance upon medical staff undergoing continuing training and education in the clinical area. Very significant expansion of the role of the nurse and the midwife in all clinical areas, requiring a significant increase in the number of nurses and midwives, both in the hospital and community, who are empowered to prescribe within agreed protocols. The expansion of nurse and midwife-led services involving advanced nurse and midwife practitioners. The empowerment of nurses and midwives to order diagnostic tests, x-rays and bloods, whether they work in a hospital or a community. The mainstreaming of the expanded role with regards to first dose antibiotic, IV cannulation for fluid balance, out-of-hours phlebotomy, nurse-led discharge and other appropriate roles within all care settings. The role of the healthcare assistant, including their job description and training pathway, must be standardised, nationalised and become the minimum required for entry to this grade. This is an essential part of frontline reform required, which should lead to best practice skill mix ratios such as 80-20 RN-HCA in acute and medical surgical wards, 50-50 RN-HCA in care of the elderly facilities, as confirmed by international research, that is, the RN forecast. Devolved funding. The INMO, as stated, is also calling for reform leading to practice where funding is devolved to wards, units and community level. Currently, frontline managers have no input into what funding is required and can work the whole year without ever knowing what funding was given to their area or unit, which leaves them in an impossible position. In simplifying organisational structures, the INMO is also calling for new accountability rules, which would see the following: the Director of Nursing and Midwifery involved at all stages in the formulation of the annual budget for the location and area. Once the budget has been finalised for that area or location, it is then devolved to the frontline manager, who is the clinical nurse manager or the head of physiotherapy, who assume responsibility and accountability for the budget, but with complete autonomy as to what service can be delivered safely within that budget, and directors of nursing and midwifery and senior hospital area managers as appropriate, empowered to seek amended funding levels to reflect changes in services demand, acuity and dependency. Staffing level skill mix. The greatest damage done to the health service in recent years has been the totally unmanaged contraction of staff numbers. This in turn is a major reason for the broken spirit and morale of frontline staff, particularly nurses and midwives at this time. As we embark on this transformational programme, we must introduce an evidence-based approach to staffing our health service at levels which optimise the well-being of patients. This process is already underway through the work of the Task Force on Nurse Staffing and Skill Mix in adult medical and surgical wards. The further rollout of this approach to staffing is fundamental to the transformation programme, and the next area planned is the Emergency Department nurse staffing. This work must be accelerated. We use evidence-based mechanisms as determined by Frontline Manager, the CNM2, to determine appropriate staffing and skill mix requirements. Health service staff, recruitment, retention and recognition. It is self-evident and very regrettable that to date neither the HSE, the Department of Health or the whole Government has done enough to address the loss of our best and brightest young professionals. Therefore, the Public Service Pay Commission must be accelerated and FEMPI unwound together with the early renegotiation of the Lantown Road Agreement in order to garner trust within staff to deliver this radical transformation. In addition, it is INMO's belief that the crisis with regard to nursing and midwifery recruitment and retention requires unique measures to be brought forward immediately to reduce current excessive workloads and improved patient care. Finally, on this issue, no matter what model of healthcare is used, the reality is that all health systems are labour-intensive and must be staffed by committed, dedicated and flexible people. This must be recognised, with the health service being an employer of choice, offering excellent pay and conditions. Funding. As we state in our written submission, the latest OECD figures confirm in 2013 that the Government's allocation to public health spending was 7.2% of GDP. The OECD figures also indicate that when this public expenditure is combined with private health expenditure, the overall health spend in this country approximates 10% of GDP. However, the manner and nature of this expenditure, which clearly reinforces the two-tiered structure, only serves to guarantee faster access to diagnostics and treatment for those who can either afford private insurance or direct out-of-pocket expenses. This is inherently unfair and inequitable. Therefore, in calling for this public health spend of no less than 10% of GDP and 12 to 14% during transitional years, we recognise that this must be done with total transparency so that it secures and maintains the confidence of all citizens and taxpayers. The phased abolition of all tax release pertaining to private health insurance, the ending of any contracting for services to provide direct care, and the phased ending of subvention to private nursing homes, recognising that this will take an extended period due to existing contracts and bed stocks and the need to develop new publicly funded direct facilities. In recognising the challenge that meeting future health costs will bring, we would draw the Committee's attention to recent papers produced by the Nevin Economic Research Institute, which reminded us that in the next 3 decades, the number of persons over 65 will move from 606,000 to 1.8 million in 2046. In addition, we face the growing epidemics of obesity and alcohol abuse, which will also increase demand upon our health service. Against this stark reality, the political system must fully understand the implications of these demographic and lifestyle changes. All taxpayers must also understand that we cannot reduce general taxation levels and provide the same type and extent of health service the population will need. In concluding, our call today to this committee is to begin the revolution necessary that will deliver a single-tiered health system, within 15 years, which will serve all people of this country equally and in a world-class manner. In calling for this, we also recognise that the health service structures and how all health service staff work must also be subject to transformation. No vested interest should be allowed to halt the pace of progress necessary to prepare for the growing demand that will be made upon our health system. To deliver this change will require the health service, including its funding and structures, to be removed completely from the traditional electoral cycle and budgetary practices. We asked you to make these recommendations safe in the knowledge that all future generations of Irish citizens will live in a more equal society with regard to healthcare, which is an investment in the future and will realise healthier communities and a stronger economy. Thank you, Madam Chair.
Thank you very much for that very comprehensive opening statement. It's dealt with a lot of different areas. I'm going to ask members now, invite members in groups of 3, so if you could just record the questions, bank them and respond then, please. Starting with Deputy O'Reilly.
Thanks very much, Chair, and thank you for the presentation this morning. I think it's fairly comprehensive. All right. A few questions I want to ask, and it's an issue that's been coming up this morning a few times. Skill mix. There's general acceptance that we could do better in terms of skill mix. There's clearly a blockage because people have been talking about this for a very long time, and I'm just wondering if we could, I think various groups have their view on where the blockage might be, but given that we have to tackle the issue of skill mix, if we could have your view on where the blockages are, what could be done to improve the level of skill mix within the health service, maybe in the short term and also in the longer term, because I believe it's not something you could fix overnight. With regard to, Martina, you referred to the broken spirit of the nurses and midwives, and indeed I think the general population of health service workers. What can we do in terms of securing, because the purpose of this committee is to devise a plan, but a plan is completely useless unless we can get buy-in. So how can we establish credibility among healthcare professionals? And finally, we discussed the ratio between private and public. I'd just be interested to hear your views on the value for money that we get for our spend on private healthcare versus how that money could be spent or invested within the public health system. Thanks, Chair.
Thank you. Deputy Madigan.
Thank you for your very comprehensive paper, Ms Harkin-Kelly, and I think midwives in particular do a huge amount of work and save a huge amount of time for consultants on a daily basis, and I would have a very strong view on that. That they should be. It's awful to hear that the morale is so down at the minute, and obviously we're delighted that you're here today so that we can try and help move forward and help find some solutions to that. Just a couple of questions that I asked the union earlier in relation to the 15 years. When you're talking about a plan over 15 years, changes in relation to technology and medical science. I mean, how would you envisage dealing with that? I mean, would that have to be rethought after a period of time? How do you envisage, or how does the INMO envisage the devolution of funding for healthcare to work? And also, do you see scope for community providers and not-for-profit organisations? So I'd be interested in your views on that. There was just also one small part when you're talking about transforming models of care and the very significant expansion of duties for nurses and midwives. In particular, when you talk about empowering nurses stroke midwives to order diagnostic tests, I think the phraseology is interesting there. You're not saying to actually diagnose, you're saying to order tests. But just from, I suppose, from an insurance perspective, and varying into the territory of a doctor's role, I'd just like if you could flesh that out a little bit for me as well, because I'd be concerned from a med-neg perspective. Thank you.
Right, thanks very much. Deputy Buckley.
Thank you, Chair. And again, thanks very much for the presentation. I won't go over the morale and so on and so forth. Again, we're hearing it over and over and over again. But Martina, you said that people were not being treated with respect within the system. Is the system actually that toxic at the moment? I mean, has it gone, that low? And the other side of it, you mentioned about the managers not having access to budgets and stuff. Surely, you know, if somebody's buying a car or building a house, that surely they know exactly how much they're going to have and how much they can play with. I find that extremely worrying that people have no control over what they're actually able to spend. If you could elaborate a small bit on that. Everything else has been basically touched on. We probably have got a pain in our head from listening to actually how bad morale has been within the whole system.
Thanks very much. Certainly coming through very clearly, all right. So if you could respond to those questions, it would be great.
Which one do you want to?
Deputy O'Reilly, in dealing with the skills mix issue in the first instance, there has been a degree of progress in relation to skills mix, and I think the submission clearly recognises that any proper delivery of care within the health service must be evidence-based, and that's the significant work that has occurred. So, for instance, there's been very significant work in the acute medical and surgical area dealing with the task force on staffing, which has very clearly identified that you need a proper skills mix which looks at the roles played by nurses and midwives, whether they be advanced practice nurses and midwives, whether they be specialists, but more pertinently in this context, the staff nurse or midwife and the role of the healthcare assistant. That work has been done. There is some willingness, it would appear, to move that forward, but there isn't sufficient willingness to implement an appropriate evidence-based skills mix, and that's what must be done. The delivery of care must be evidence-based. It must be based on an acuity and dependency assessment which looks at the type of patients you're caring for, the appropriate professionals and other health service staff which should be available, and they should all be appropriately trained, including, as we've said in the submission, the minimum training for, we'll say, the healthcare assistant within the system, and obviously then the regulated professionals, the staff and nurse and midwife grade. The blockages specifically you asked to address, I think there isn't a willingness to understand and to accept within the system that reductions in the levels of professionals and the appropriate personnel available to treat patients is causing within the system difficulties such as increased waiting lists, increased emergency department, trolley figures, but also very importantly, the RN forecast shows us that there is increased mortality rates when you don't have the right skills mix within a particular work location. And that I'm focusing there on the medical and surgical inpatient areas, but we also have to look at the maternity strategy as well, and the requirement for the appropriate number of midwives to birth, I suppose with a nod to Deputy Madigan's points, which we'll come back to as well in relation to the role of midwives. So the requirement is for evidence-based. Nobody can spend money on a particular person or profession's call for anything. It has to be evidence-based, and the evidence base has to be what is the acuity and dependency and or birth rate, depending on the area you're working in, who are the appropriate professionals to meet that, and will the system then accept that those staffing levels and that staffing mix has to be based on patient need and not based on the current budget allocation. And we don't have to look too far away to the terrible realities and multiple deaths and very significant systemic difficulties which arose in the neighbouring jurisdiction, where budgets became the primary driver of what care would be delivered, not the quality of care required. And we have to move away from that system and towards a system which recognises the minimum level of professionals and other staff which are necessary, and we need to move forward with that.
Chair, just to supplement on that,
yeah.
You referenced the issue of budgets, but is there not scope for savings to be made within the area of skill mix as well? Is there not? And I know that it shouldn't be driven only by a cost-saving measure, but would you see that there might be scope?
Very realistically, depending on the patient group that are available and what the research says, every area in the health service should be staffed based on what the acuity and dependency of the patients demand. That can result in cost savings, or it may result in a cost increase, to be honest. But it must be evidence-based, because we have to deliver care on the basis of what evidence, which can be publicly accounted for, on the basis of what evidence has suggested, not what the INMO said or what somebody else said. It is what the evidence tells us is the necessity for that patient. So I would willfully acknowledge to you that there could be savings, but I also have to be honest and say to you that it could result in a cost increase. To address the value for money, if I might issue, in relation to the private and public healthcare, there is a misnomer out there that private healthcare is cheaper healthcare. Now, in our research, preparing a health strategy statement for our own organisation for the consideration of the public and in our submissions to this committee and other interested parties, we've looked at the delivery of healthcare across multiple jurisdictions. One wouldn't have to look too far. You can look to the West, to the United States, and the predominance of private healthcare within the delivery of healthcare, which has resulted in a huge increase and a disproportionate actual expenditure on healthcare versus a very low delivery. But if you look to the United Kingdom and the commissioning of care in the private sector, the Care Quality Commission in the United Kingdom has recently sounded significant notes of caution in relation to the ability to regulate and the quality of care that is being delivered in that jurisdiction arising from the expenditure in the private sector. Then, of course, there is also the research in the United Kingdom which would point us quite clearly towards the fact that it is actually more expensive to deliver the care in the private sector. If we look at the professionals who will deliver care in the private sector, they must be procured from within an international labour market for professionals, so they will not be paid at a lower rate. And we see within the private sector now increased sign-on bonuses being offered for registered nurses and midwives, which are indeed drawing recruits away from the public service into the private sector. So the amount paid to the staff will remain the same. There is then the extracted profit, which is obviously the raison d'etre of any business delivering a service, and there isn't the ability to, in the same manner, regulate the delivery of care. So we don't believe that the value for money argument holds water. If you say you're getting greater value for money, we believe that the research shows that it actually costs more. We believe that the labour market doesn't support paying people less to deliver the service, and therefore why should the state be funding an additional layer of expenditure, which is the profit margin, which is involved. Of no difficulty with profit margins in a general sense, but we're here to deliver a health service to the nation, to maintain the health of the nation and to improve the health of the nation, and I believe we're illegitimately spending additional money to do that, and we don't have any reasonable value for money analysis which points to either higher quality or reduced costs, which should have the state delivering it, and therefore it should deliver it on a direct employment basis. I perhaps hand over to my colleagues to address some additional points, if that's all right.
Through the Chair, Deputy O'Reilly, you referred directly to the comment that I made throughout the opening statement with regards to broken spirit. Yes, that's the best possible way to describe it, and I think Deputy Buckley may have alluded to that as well. In terms of what can we really do to garner credibility with this committee, the immediate is to attract back those that have gone to foreign fields. 7,500 nurses have gone to the UK alone. We need to incentivise, the remuneration for nurses back in this country. We have to retain them. The cost of spend on the training of them alone, and then to think that we export them abroad. Their terms and conditions, their ongoing education and training, and evaluation of them. Just at a meeting last night, the sense of enemy and helplessness in the room was palpable. And yes, we do have to beat that drum, and we do have to reiterate it time and time again, because it seems to be falling on deaf ears of government currently. And yes, they need incentivised packages for coming home, whether that is monies for rent, whether that is extra money for their travel, whether that's for moving back, whether it's for further funding for their education, whether it's incentivised over a 2-year span or a 4-year span, whatever, it desperately needs to be done, and it needs to be done now.
And on the issue of devolving budgets? Sorry. I think a couple of people raised that. Yeah.
Yeah, just on the question of budgets, we have a situation where we've gone from directors of public health nursing, for example, being able to be able to assess the need and order and deliver fairly promptly aids for people. That now requires a very elaborate business case to be made for everything. It delays the delivery of service, and sometimes you don't get an answer. It can take months, and unfortunately the person who needs it has moved to another place or gone altogether before you deliver it. So we have now a situation where the lack of ability of direct heads of service to command their budget is actually delaying and preventing patient care in many cases. There needs to be a huge look at that. We've gone from a fairly direct management reporting structure to a very indirect one, and we've gone, quite frankly, in the communities from a very accountable system where local regional health authorities staffed by or serviced by elected members at least could ask questions about the service that was provided, to a situation where nobody could ask any questions and managers answer to managers only. We've a terrible lack of governance, and that lack of governance has led to a situation where the actual heads of the service have very little control or no control over whether they can replace the staff or whether they can supply what the person needs. And that also happens in hospitals. So there's a pushing back, particularly of nurse leaders, in terms of budgetary control and ability to deliver services. That's what has happened.
Okay, briefly.
Just very, very briefly in that. So technically, I mean, look, we call a spade a spade. A child goes in for a specific operation, needs a hip speaker chair or something. Obviously, that child needs that chair. Are you telling me that in 2016, that in hospitals in this country, that we don't have the capability, or somebody doesn't have the capability, or the leadership, or the accountability, or our responsibility to go, that child needs a specific chair before they leave this hospital, but I have to make a specific business case and it's going to take too long?
That's what happens. Business cases.
Okay, thank you. Deputy Dr. Harty.
Thank you very much, and thank you very much for coming in. Just two questions. In relation to recruitment, which is a huge problem and probably the most pressing problem in the Irish Health Service, we had the INMO in just before you, and they identified that salary was the fourth in priority of wishes for NCHDs to remain in this country. Working conditions, length of contracts, career progression and hope for the future were ahead of salary. Perhaps you might just comment on how those can be addressed. And the second item is in relation to the transforming of medical care. You suggest that all new consultant contracts and GP contracts should be public-only contracts. How do you envisage that working? I can see perhaps consultant-only contracts working in a hospital where there are a number of consultants who can take over the care of non-eligible patients. But I don't understand how it would work in general practice, where only 47% of the population have an entitlement to a medical card. Obviously, if you move to a single-tier service where everyone is covered, that would be the case, that you could allow GPs just to have a public-only contract. But in the present situation, that wouldn't be possible. And if everyone is eligible, why would you have a contract and not go to a salaried position? Thank you.
Thank you. Deputy Naughton.
Thank you, and thank you for your detailed submission and presentation here this morning. You indicated that any move to a new model would have to include a review of our bed capacity, particularly in the hospital setting, to address the severe overcrowding and the numbers there. And this is a question I asked to the previous witnesses. I'd be of the view that any bed review would have to be independent of government and the department, because it's important that we instil public confidence in this. And I would just like to know your views on this, or have you a figure? And I'm very conscious that Mr. Matthews has referenced it being evidence-based, but if you would have a figure on that, or approximate figure on your views on that review and how that will be conducted, that bed review. Thank you. Okay,
thank you. I just have three questions to raise with you. You said in your presentation that, you know, nurses want to take on new responsibilities and new duties. Why is it that, what's stopping that? I'd also like to ask you your view on the present arrangements, and particularly in light of the fact that nurses will be leading out on chronic disease management. That is proposed currently to be done by way of practice nurses. And again, I'd like to ask you your view on practice nurses being employed by GPs, and whether or not that's the optimal way of providing that service. And finally, my question in relation to the recruitment and retention of staff. It's come up a couple of times over the last few months with us about the potential for having some type of scholarship scheme whereby, nurse training would be funded, and in return for that, nurses would commit to staying within the Irish system for 3 years or whatever length of time. Have you a view on that kind of approach? Thank you.
Okay, if I might just come back on the recruitment part first. When you outlined what the INMO said about doctors, in the case of nurses and midwives, money is a big issue. The overall remuneration package to attract nurses simply is not good enough to get the people who've left this country back. All of the OECD countries are facing a massive shortage of nurses and healthcare workers generally in the next 2 decades. We are competing in an international market which is offering better, and we can't do that. We are competing even in an Irish market where private providers are making better offers to nurses to move to them. It's not realistic. The Bring Them Home campaign showed just how unrealistic the efforts are. So, not the same as doctors or what the INMO have said, money is a major issue in terms of getting those people back here and keeping them here. It is a major issue. The other issues we do share in common, the lack of educational opportunity. The last 8 years have seen a really pullback on the educational opportunities for new nurses coming in or existing nurses. There's a huge appetite among nurses and midwives for continuing education. We see it through our own services that we provide, but the funding of that has been left to individuals in many cases and has been pulled back. When you attract someone from another country back, that's one of the reasons why they leave again, because they lose what they've had in England or wherever they went in terms of educational ability and career progression. So those things are equally important for nurses, but money is much higher, I think, in the, as you've outlined, the list of priorities that you've heard from others.
Just to add to that, unlike within the medical profession, the 2011 Nurses Act doesn't set aside times for studies for nurses as such. So an awful lot of the nurses and midwives actually do ongoing and continuing professional development within their own days off. The only leave that they're currently getting at the moment, and even that is being pushed, is mandatory training. So that's the realities of the vagaries that exist within the system currently. Sorry, Dave.
Chair, I might address just a number of your questions in relation to the new responsibilities and duties that nurses and midwives in some locations or in many locations have assumed, but the necessity for greater progression. First of all, the blockages are twofold in my view. One is a systemic willingness, or unwillingness should I say, to recognise the full contribution that nurses and midwives can make in specialist and advanced practice roles. And the international research is patently clear in relation to the ability of nurses and midwives in specialist and advanced practice roles to manage both complicated and uncomplicated care within a variety of settings, whether that's in primary care, acute, elderly care, mental health, and the ability to do that, which in turn increases patient experience, or the positivity of patient experience, has been shown in evidence to reduce hospital admissions, to increase the integrated nature of the care. And that's the big block within the siloed system that we have now, which is ultimately leading to people not getting the care, which in turn is leading to the incredible pressure in the secondary and tertiary systems. So the block...
That's a principle that isn't being recognised.
It is a principle that isn't
management.
Absolutely. It isn't being sufficiently recognised, and it must be recognised. Now, that's one element of it. The other element of it then is the tortuous process that has organically grown for the development of advanced practice roles. And what we need to move to is the model that's been implemented in other jurisdictions, which is a credentialing framework using the Nursing and Midwifery Register, which recognises the skills and competencies which are available in the graduate workforce, recognises and supports the ongoing education of people and experiential learning, credentials that, i.e. annotates it to their register, and then allows them to progress to the advanced practice role. And it must be within the HSE service plan and or whatever or whoever will manage the health service going forward, and our recommendation to health authorities with the Department of Health with the policy lead, to embed advanced practice roles within within the delivery of care across the models of care to ensure that people get the right professional at the right time, delivering the right care. And it's the credentialing framework and the willingness of the system to deliver that. I might, in tandem with dealing with that, Chair, deal with Deputy Madigan's point, which was a concern in relation to perhaps a med-neg issue and the advanced practice role. Well, the answer to that is quite simple. The issue doesn't arise. It arises the standard of care that must be delivered is based on the level that the practitioner is operating at. When people reach an advanced practice role, international research and all the safety literature shows that those advanced practitioners are competent and capable to deliver and to manage care, both complicated and uncomplicated, across a range of headings, and to be competent and capable to discharge people and cross-refer between services and professionals, between advanced nurses and physicians, to ensure the delivery of care that is needed. Additionally, you asked for a comment, Chairperson, in relation to the chronic disease management and the role of practice nurses. There is absolutely a necessity, which I've already addressed, to have nurses embedded at a specialist and advanced practice level to ensure the proper delivery of chronic disease management, which is the issue of our time, particularly looking as we are at a doubling and more of the elderly population as we move forward in the changing demographics. Practice nurses should not be privately employed. They should be employed by the public health system, because if we're to have an integrated delivery of care, you cannot have people siloed off at the side employed by somebody else. You have to have a managed and delivered service where somebody is within that service working as part of a team, not siloed off in a separate location. And they have to have access then to the supports and systemic advancement opportunities which come within the public health service that we're envisaging, which will automatically say, well, you have a practice nurse, that practice nurse is working at that level. There may well be a specialist role or an advanced practice role, whether it's for chronic obstructive pulmonary disease, whether it's for cardiac, epilepsy. There are good models out there throughout the service, but they must be brought into the service, because where they are currently, the opportunities are not there and the standardisation is not there within the service to allow that progression.
Sorry, is there an issue there? I mean, if you had a big bang and obviously changed to a totally public system, that'd be a different matter. But in terms of transitioning to a new type of system, I mean, obviously there's a lot of GPs that want to continue on in private practice, single-handed or group practice. And the arrangement there is that obviously they employ practice nurses. I mean, do you see that continuing in a transitionary phase?
Our view would be that even if when you have that transitionary phase, and you know what our view is in relation to the publicly delivered service in the future, there's absolutely no reason why those practice nurses cannot be brought within the public service and allowed then the opportunity to benefit from the integrated team approach. Now, there's a difficulty, of course, where you have a siloed individual providing care, but you can have, with agreement obviously, that person coming within the public service, having the availability of the team approach to increase the integration, having access to the other professionals within the primary care service, having the ability to cross-refer, and they should be brought within the service to maximise integration within the transitionary phase, because otherwise they'd remain isolated where they are currently.
Okay. And the idea of some type of scholarship scheme, would you see that having a role?
Yeah, the difficulty, Chair, is it's not in the training. There are nurses applying on the CEO year in, year out, CSO, with regards to nursing and nurse training. It's the retention of them after that immediate 4 years, and I think it was Deputy Buckley as well who would have alluded to it. There's this kind of misnomer with regards to what actually a nurse is trained to do over that 4-year period. They are a graduate degree student who progresses to a higher diploma, who progresses to a master's, and in many cases is at PhD level. It's not the immediate 4-year period that's problematic. It's the immediate periods after the 4-year period. However, I would caution that if any scholarship came into place, that there was no stipulations with regards to what their salaries would be in the post-immediate period, because what we envisage as a union is that nurses should be paid at the same salary as all other allied healthcare professionals. They have exactly the same qualification. There is no differentials. In fact, I would go as far to say as they are the most holistic individuals who sit within the health service currently, in that they deal with the physical, the psychological, the social, the spiritual, the environmental and the economic, and that's what they're trained to do.
In addition, Chair, I would say to you that the issue is an emigration issue, but there are elements of emigration which have always happened with all health professionals, and we've all benefited from that. The difficulty is the net migration figure, which hasn't resulted in people coming home. Now, the difficulty is, if you introduce a scholarship scheme, notwithstanding the inequity that would be that people are trained and provided with a level of education, but you should be disadvantaged when you're from one particular occupational group, because the terms and conditions are not such as to retain you. So what we're going to do is indenture you to the service. There's an inherent inequity and unfairness in that. What we need are the terms and conditions and work environments that people want to work in. You want to become an employer of choice. An employer of choice in nursing and midwifery has proper terms and conditions of employment, comparable working hours with other health professionals, and one of the greatest barriers for our colleagues is the availability of a reasonable and certain career progression ladder, the ability to move to a specialist role and the availability to move to an advanced role. Our graduates will be on Skype interviews with London hospitals, offering them immediate specialist placements, immediate education and immediate advancement. They'll be on Skype interviews with New Zealand, with the jurisdictions in Australia, Canada, the United States, all immediately offering them jobs, while here they can't get a promise that they can even work in a particular department for a particular period of time, never mind the promise that they'll have a career advancement. We need to address those things. We need to make it an employer of choice, and we need people who want to work there, not people who are indentured to the service.
Just in relation to the scholarship, there is one area of where it has a benefit, and it has only worked to a very limited degree because the numbers allowed on it have been very small, and that is for people who already work in a health service in a related care delivery training to be nurses. There is a scholarship scheme. Again, funding has tightened, but there is potential there because there are lots of people who could progress very successfully under that scheme. And if there is scope for a scholarship, it's among that mature existing healthcare occupational group.
Okay, fine. Yes, fine.
Question in relation to public-only contracts for consultants and for GPs. Perhaps you might address that.
Look, it is quite clear that there's a transitionary period within the delivery of health services. Our vision is for a publicly delivered primary, acute, mental health and social care delivery service, and it is within that context that we have recommended the public-only contract, because we believe that you cannot have, if you are going to organise and deliver an integrated service where everyone, if you like, is rowing in the same direction under the same policy, you can't have people who are not within that service, and that is our view. But we do see a transitionary issue where you have eligibility, but we want to move towards universal eligibility within the primary health system, and that is how we would address the issue.
If you have GPs who are publicly have a public-only contract, surely there's not much of a jump between that and a salary GP. What would be the advantage of a GP having a public-only contract and not being salaried?
Well, I don't necessarily think that there is any particular differential, and I'm not sure there's much between us. We would believe that the GPs should be within the system, employees as a salaried system, and perhaps it's a matter of nomenclature rather than a particular difference within the system. If you get my point, we don't see it. We don't see a huge. We would rather see a GP as a salaried person within the service. We recognise that there's a current cohort who are in private practice, and it's how you bring those people in and how you allow people who have not or who don't want to come in, allow them to continue to have their contractual rights and manage that transitionary period. But going forward, we would see all deliverers, the same way as a consultant is delivering a service, that the GP would do likewise.
Okay.
In relation to additional bed capacity
yes,
and independent review and your views on that.
There's absolutely no difficulty whatsoever. In fact, our belief is that the public must have confidence in the delivery of a service, and we've said very clearly that no single group or single occupational category or single influencer can act as a vested interest to block either the future advancement of the service or to, I suppose, unduly influence the service in the future. And that, in that context, we believe that there should be equivalent to, whatever you call it, a public health inspectorate who would monitor the delivery of care and who would ensure value for money, so that when we're saying you devolve budgets down to ward and unit level, it's not that nobody monitors that, it's not that anyone has a free-for-all, it's that they're required to operate on their evidence base in relation to staffing numbers. And to direct, not avoiding your question, Deputy Naughton, specifically on the bed review, yes, there is no difficulty at all. We can look at the OECD averages, you know, of 2.8 versus 4.8 per thousand of population. We can look at the loss of 2,000 beds. We can look at the fact that a previous Minister for Health, when we were reducing bed capacity, was also recommending a cushion, if you like, of 6 co-located hospitals, which would have up to 400 beds each, which never materialised. But the point is, we have no difficulty and we have no fear of an independent bed review. We know that we have to reduce the number of patients who are fit for discharge who should not be in the hospital, but it is our belief, and the evidence will declare, pending moving to a more integrated primary service, and that's why we're recommending the higher spend in the interim period, that you do need more acute beds. We have no objection whatsoever to an independent study which would receive contributions from interested parties and reach a determination. We believe the OECD figures point to the necessity for it, and if nothing else, the emergency department figures can leave nobody in doubt, as with the waiting list figures, that there is a necessity for a mixed inpatient bed capacity, both 5-day and obviously 7/7.
Okay, Deputy Brazel, finally.
Very brief question, and I hear, and whether it's anecdotal or otherwise, you know, the package that's available to nurses in the UK, Canada, US is far greater than, or far better than what's available in Ireland. Do you have a set of figures and salaries, for example, for, you know, starting salaries for an Irish nurse midwife versus UK, so that we could have some sort of a benchmark where we could say, look, this is where we need to be? Because you hear, you know, my niece qualified recently, and she's very thankfully that she's got a job as a midwife up in Galway, and she's very happy with her permanent job and so on, and has absolutely no intention of going anywhere. So, you know, there are examples, I suppose, of students and people who want to stay in Ireland and are happy to stay. But I'd like to maybe, and might be something for a follow-up, I don't expect you to have it now, that you might send us, so if we could look at something factual rather than anecdotal and say, look, this is what you can get.
International comparisons are notoriously difficult because the cost of living obviously influences what you earn. The ICN do an international comparison based on PPPs, which gives you the value of an income. There's a lot of that information, but we can make direct comparisons with the recruiters.
You know, I think most people are, I mean, you know, I emigrated myself in the 80s. I knew the salary I had in Ireland. I knew the salary I was going to in the UK. And, you know, you can make a fairly...
Yeah, I think those figures with purchasing power would be the relevant ones, particularly in relation to housing. Yeah. Whatever about your niece living in Galway. In Dublin, it's kind of prohibitive because of the cost of housing. Now, so I think you do have to factor in the cost of living with salaries.
Provide the comparative.
And starting salaries, but also then the scale in terms of how quickly or otherwise the person progresses up the scale.
Living in Australia and Canada, you know, is substantial as well, you know, so it's
If I might say, Chairperson, there's no fear in having the purchasing power figures and the actual figures. No, you'll have both, and then you'll be able to make the comparison.
It's you know, it's just good to have.
Oh no, absolutely. Well, there's nothing.
We're trying to standards we're trying to set them.
There's no subterfuge. The data is there, and we'll happily provide it along with the purchasing power figures, because we do believe that is a relevant factor, as well as you say, as the raw analysis of the actual figures, and we'll certainly provide that to you, Chair.
Okay. Finally.
Very briefly on that. I think clearly there's an issue because they're going. So it might be the salary, it might be something else. And definitely the purchasing power figures, I think, would be good to compare, and we can compare the basic pay scales and all of that. But there are other factors at play. Is it career progression? Is it staffing levels? Is it morale? What is it that's causing them to go? Because it can't just be money.
I think, Chair, Deputy O'Reilly's point, to give a fair analysis and a fair answer to Deputy Brazel's question, it will be necessary for us to put to you, as we have already, not only the raw figures, but the purchasing power, but also the points we raised, which is that you have automatic access to career progression, automatic access to specialist working areas, automatic career progression to specialist and advanced practice roles, lower staff numbers to patient population, and a much improved work environment. So I think that we have both objective data and subjective perceptions which are equally relevant and valid, because people are leaving, as you say, and we can provide those both to the committee to assist in your understanding of the overall situation.
I think, though, at the moment, the poor work environment is absolutely crucifying those in it and driving many out of it. The stories, and I know you've heard it, but it really is appalling. The workload, the pressure, the inability to control the numbers that come at the service, and the nurse or midwife is the one, and the care assistant who works with them, who takes all of that. It keeps on coming. And it's an appallingly bad workplace, and many who look at it from externally will not go into it. They say, why would I go from this workplace to that one?
Medical Council surveyed doctors on the reasons. Deputy Harty referred to that earlier, and I think it was just very interesting for us to hear the results of that survey. I don't know if you've surveyed your own members in that regard, but we'd be very interested just in seeing any information that you have on the underlying causes apart from the...
Absolutely.
All right. With that, I'd like to thank you all very much for your contribution. It's certainly a very significant contribution, I think, to the work of the committee, and we appreciate your time. Thank you. All right, members, that completes the business of the meeting. The meeting stands adjourned until this day fortnight. Right.